The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with Inside JACC. And recently the Ceylon T trial was reported, and we're pleased to have that paper in press. And that looked at the value of triple antiplatelet therapy, the third antiplatelet agent being Cilostazol, and whether or not that was effective in preventing adverse outcomes long-term after intervention. And here to discuss that with us in an interesting twist is the editorialist and one of the reviewers of that manuscript, Dr. David Antoniucci. And David is professor of medicine at the University of Florence. And tell us, David, can you review the specifics of that paper for us?
Yes, and this is a very interesting study also because it's a negative study and shows that triple antiplatelet therapy on a cohort of 800 patients was not effective in the improvement of outcome of patients who received drug-eluting stents. And this despite the fact that, however, Cilostazol has some effect on in vitro tests showing that patients with triple antiplatelet therapy have a more platelet aggregation inhibition.
And in fact, there have been two other trials that have shown that Cilostazol was of value. And
some value was shown in the previous two trials, yes. Yes, but I'm confident that this is the truth in this third trial, because in order to decrease effectively the risk of thrombosis and clinical events related to death thrombosis, you have to achieve a very good, profound inhibition, also in vitro test. And Cilostazol have a little value in adding the effect on platelet aggregation inhibition. Thus, I think that there is no role for triple antiplatelet therapy today.
So you think that the issue was triple antiplatelet therapy, or the issue was Cilostazol specifically?
Cilostazol, both things, because you have to start with the idea that at least 20-25% of patients receiving dual antiplatelet therapy are no-responder or poor responder to clopidogrel. Thus, if you use a third drug that have a small effect, however a significant effect, but a small effect on platelet reactivity, this will not result in a significant impact on clinical outcome. This is my idea.
So do you think that in the future, in these patients, we will move toward other agents like prasugrel or ticagrelor, or do you think we will increase the dose of clopidogrel?
As shown by the Gravitas trial, if you increase the dose of clopidogrel, you have really a very small response. And this is also my experience. I published with you the RECLOSE trial several years ago. This is a field of investigation showing that maybe that poor responders to clopidogrel are generally at the risk of thrombosis. Obviously, if you have a patient with 7 drug-eluting stents, it's very likely that the thrombosis will occur just in the stent. But I think more importantly that this patient, this is really a strong marker of thrombotic events, not necessarily into the stent, but also in other part, in other district of atherosclerotic disease. This is a very important issue. And we don't know if with the use of prasugrel or ticagrelor, we have all responders, but we don't know if this risk marker may be changed by these new drugs.
Are you at the moment, one of the issues we had with this study was that they gave the Cilostazol to everyone, and maybe a better strategy is to identify those patients who are poor responders to aspirin and clopidogrel and to selectively treat those patients. What is your
Yeah, there is a rationale for this, because if the patient is a responder to clopidogrel, in this patient you will achieve the same result that you can achieve with prasugrel. It's a good responder. You have an ADP test of 50 or 40%. These patients in the same risk profile as treated with prasugrel.
So, last question. At the current time, are you measuring routinely any facet of platelet reactivity in your patients?
I think that this should be very useful.
Are you doing it?
Yes, we are doing from the last 5 years, and we have a big lab in our hospital. All tests, but our standard is light transmittance aggregometry.
Light transmission. Very interesting. Well, this is a hot field and a lot of debate still going on, and thanks for sharing your extensive experience with us. I'm Tony DeMaria. Thanks very much for viewing.